Sorry, it's just... So this is my presentation on cardiac arrests. And I'm Stephanie, I'm one of the IMT doctors currently rotating through South Manchester. So we'll just get started then. So this is just a bit of an overview of cardiac arrests and a bit of stats really. So 85% of cardiac arrests occur in hospitals and mainly on the wards. So this is something that, you know, throughout our careers, everyone will see regularly. The initial rhythm is shockable in only 17% of cardiac arrests. So most of the arrests will be non-shockable rhythm, CPR only. ROSC is achieved in approximately half of those treated. So this is of all cardiac arrests. And 23% survive to hospital discharge. So this is something to, when you're having DNAR discussions, it's something that often is discussed with the patient to say, you know, 50% of the time we get people back when they arrest, but only 23% of these actually make it to hospital discharge. 83% of those survive usually do have a favourable neurological outcome, but this is quite general, so it's hard to say what favourable really is. So this then drops dramatically if you have a non-shockable rhythm. So again, with DNAR discussions, it's always good to think about, do you think if this patient arrested, they would have a shockable rhythm or not? So a patient who's elderly, who's come in with sepsis, and who's got loads of comorbidities, you know, they're more likely to have a non-shockable rhythm than a younger patient who's come in with an MI. So this is always something to just bear in mind. So this is just taken from the RESUS guidelines. So this is the CPR, early recognition of what's happening, early CPR, early defibrillation, and early advanced care, which will all help improve survival. So this is called the chain of survival. So I'm just gonna go through each one in turn and highlight some like important things that, you know, I think are important during the arrest situation. So even kind of before this, I would say it's important to think about defining roles. So any RESUS team, it's always good to think about, okay, what experience does everybody have? So do they have ALS? Do they have ILS? What does everyone feel comfortable with? And sometimes it is good to define roles. So, you know, who's going to do airway, who's going to do access, who's going to do the defib. However, although this is something that's often, you know, advocated, sometimes it can kind of all go to pot when you get there and you assess the situation, and the roles might need to change depending on that. So there's also an element of being fluid within this. And kind of the main thing about early recognition and call is recognizing the peri-arrest patient. So I've put some common peri-arrest situations. So someone who's in shock or septic, so any kind of shock, a syncope patient, anyone in severe heart failure, anyone who's got an arrhythmia or a new MI. So as an F1, I'd say this is probably something that will be you will more commonly do, especially if you're covering wards. So you might be asked to see an unwell patient, and it's about escalating early to get them seen by the medical, you know, the rest of the medical team, to kind of prevent an arrest, but also to put the arrest call out early. This is kind of one of my main points, is it's never too early to put an arrest call out if you think somebody is unwell and they're likely to arrest. From my experience, no one is going to be angry with you about putting an arrest call out early. And actually you might save that patient's life. Another part of kind of pre-arrest is identifying patient who would be for do not attempt for resuscitation. So again, as an F1, this is not often something that you would have to do, but sometimes something you might want to highlight to your senior on a ward round is, you know, what do you think about their escalation status if it hasn't previously been discussed? Because obviously this will prevent unnecessary CPR and trauma for that patient if you know, as a medical team, we feel that it wouldn't be successful. And the other thing I've put on is just identifying specific circumstances. So I've had a couple of these incidents that have happened to me. So anyone who comes in with a big PE, kind of deciding at that point, okay, if this patient's arrest, are we going to do CPR? Because obviously with PE, there's a specific algorithm of, you have to do up to an hour of CPR once you've thrombolized them. So would this patient be for thrombolysis? The other things to consider are pregnant patients. So I previously had a very unwell pregnant patient who was 32 weeks. So thinking about, do we need to liaise with the obs and gynae team? Because if this patient arrests for whatever reason, what is our plan going to be? So this is all just about generally pre-planning the arrest. The other thing I've put on here is long QT. So I've also had a patient with congenital long QT syndrome, and we liaised early with cardiology to say, okay, if this patient arrests, do we give amiodarone? Because amiodarone can prolong the QT. Would that make, that person more unwell? So just kind of identifying things that if in the arrest situation, how would we change things? So I just wanted to open at this point to see if anybody has any comments about this from our other medical team who've been involved in this situation. So I know we've got an F1 and we've got Ahmed on, if anyone has anything they'd like to add.
I think what you said is spot on, really. I think it depends, in terms of the cardiac arrest roles, it depends which hospital you're at. There's different setups. So some places they have a team meeting at the start of the shift, and that's when they allocate the roles. But in most places I've worked, when you arrive at the cardiac arrest, that's when you sort of work out, that's the first time you'll often see the cardiac arrest team. And I kind of suggest that if you're leading the arrest, or even if you're not leading, actually, it's quite useful to allocate the roles when you arrive. So, find someone, or, I'm going to keep the notes, or you keep the notes. And it's also useful to have someone to review the notes, the drug chart and the bloods, because sometimes that will give you the diagnosis or what's going on. The long QT, don't give amiodarone in long QT. We usually give beta blockers, actually, and that tends to, in a lot of patients, it reduces the QT. So yeah, avoid any QT prolonging drugs in those patients. Yeah.
So from my experience as an F1 as well in this role, lots of the time, the main things are you might be identifying people who are unwell and peri-arrest, but also in the arrest situation, often as an F1, you tend to be either doing chest compressions or getting the notes and keeping an eye on the documentation. So I don't know if any of the F1s have any comments about that, but that tends to be kind of more the role in this part of the arrest.
And Stephanie, when you put a peri-arrest call, is that the same team that comes as if you put an arrest call?
Yeah, so I would still do the same, like put an arrest call out for a patient who you think is peri-arrest and likely to arrest. Because just from experience, really, when people are peri-arrest and very unwell, they deteriorate very quickly, and you want everybody there because it's going to take some time for everyone to get there. So some hospitals, again, have different systems. So when I worked at Warrington, they had a MET call process. So anyone who scored over 5 on their news chart, it activated a medical emergency team. So then you would get the reg, the F1 and the SHO and some advanced care practitioner. So, that would be probably more appropriate if you're in a hospital that dealt with that. So it's kind of like find out what's in your hospital as well and what's on offer. But, as I say, if you think someone's peri-arrest and very unwell, put an arrest call out if in doubt. Okay.
The syncope patients are definitely, syncope looks like a cardiac arrest. You can't tell that it's syncope usually until after they've woken up, a few minutes later. So when I was doing when I was medical on call, we used to get loads of these patients for syncope that were put out as cardiac arrest. That was the right thing to do. Absolutely.
So this is the first part of the Rhesus algorithm, which is related to this. So, you know, just to highlight this. So someone who's unresponsive, not breathing or gasping, call the arrest call team. So just so that we can link it to the algorithm. Okay, and then the next part of the chain of survival is early CPR and early defibrillation. So this is again taken from the Rhesus algorithm. So at some point everyone will do ALS, so all of this will be covered then. So I'm not going to spend too much time on this, but essentially CPR 32, and just something to bear in mind is when you're assessing rhythm, always assess for pulse as well. This is something that's not often mentioned on the algorithm, but obviously it's important. Then you're identifying, is it a shockable rhythm and is it a non-shockable, or is it a non-shockable rhythm? So usually whoever's in charge of the defibrillator or leading the arrest will identify this. So shockable rhythm algorithm is you can give a shock immediately as soon as you find that someone's in a shockable rhythm. Previously, I think you waited until 2 minutes until you assess rhythm, but you can do it from the offset now. You can give amiodarone and adrenaline. And then on the non-shockable rhythm side, then it's adrenaline. Some patients flip between two sides, but it's just to remember that, you know, obviously if they do flip from non-shockable to shockable, you can give a shock. And if you go from shockable to non-shockable, don't give a shock. That's pretty much the two sides. Okay, I just got some rhythm strips. So just to identify, you know, what rhythms you might see, and just so that we refresh on what is shockable and what is non-shockable. So I just wanted to see if anybody could tell me what this rhythm strip shows and whether it's shockable or non-shockable. Anyone?
So broad complex tachycardia, it's regular, so it's probably VT and that's shockable.
Exactly.
Check if it's pulseless.
Yeah. So I think, again, these are just to highlight that actually sometimes it can be quite daunting to think, oh, what's shockable, what's non-shockable, am I going to know in the situation? But, you know, actually often it's quite obvious. So the only thing you need to really identify is VT and VF. Anything else is going to be non-shockable. So what would this be?
So this should just go under pulseless electrical activity.
Yeah.
Assuming they didn't have a pulse.
Yeah, exactly.
So non-shockable.
So it's a non-shockable. And then last one.
That looks like VF.
Yeah, exactly. So shockable. So something else that's often, so once someone goes into an arrest, is we think about the reversible causes. Again, this is something that will be covered in your ALS. So it's not I've not got an exhausted list. So there's H's and T's. So I don't know if anyone, I've obviously given you the first one, but does anybody know any of the other ones, any of the other H's?
There's hypothermia.
Yeah.
Is that hypotension?
Yeah. Hypotension, I'm not sure. It's hypovolemia, but it's
hypovolemia, which could manifest as hypotension. Yeah. What have I missed out? Hyperkalemia.
Yeah, so any electrolyte problems. So hypothermia, hypokalemia, hypokalemia, and these are all electrolyte ones. So basically acidosis, hypoglycemia, hypovolemia. So it looks like more here, but the middle three are all basically electrolyte problems. So never forget to check a BM in somebody who's arrested, but whoever's leading the arrest will usually go through these. Often they say them out loud. Well, you know, what do we think this is reversible? What do we think the reversible cause is? And then the T's, if anyone knows them.
Do you want me to go again?
Does anybody else want to contribute at all?
So is it tension pneumothorax? Is that one?
Yeah, brilliant.
Tamponade?
Yeah. Fantastic.
I can't think what the other ones are.
The thromboembolism as well.
Yeah.
And toxins as well.
Toxins, yeah, exactly. So tamponade, thrombosis, toxins, and tension pneumothorax. So the other thing you might be asked to do is listen to the patient's chest while they're during the arrest. And I suppose from a cardiology perspective, as we are on a cardiology talk, the main two things on here that would be cardiology related are tamponade and thrombosis. So from a tamponade point of view, if we think that the patient's tamponading, then they might need an emergency. I can't say the word now. What's the word when you do the pleural? Is it not? It's not
pericardial-centesis.
That's it. Yeah. Or thrombosis, when you might need to thrombolize them. And again, just to remember that you'd have to do 60 to 90 minutes of CPR after thrombolysis. And then from an MI point of view, they might need a primary PCI. So yeah. So you don't often see these just from experience in a, district general hospital. You're more likely to see, electrolyte problems or hypovolemia than you are the other issues. They do happen, but they're not as common. So I've just wrote down the side, things to think about then to help you assess for these. So auscultation, blood gas, blood glucose, temperature charts, and temperature check to just see what the temperature's been like. And then the other thing is an echo. So the RESUS guidelines say that, ideally we do an echo at every arrest because it can help not only assess for some of these problems, so like tamponade, regional wall motion abnormalities, which might suggest an MI. You can look at the IVC to see if someone's had a massive PE, but also to assess for hypovolemia. But another thing is that they also think it can help predict prognosis based on how the heart's function. I'm not an echo specialist, so I don't know exactly how this is done, but I've just got a picture of the placements for an echo. And the most often position is subcostal because it's the easiest thing to do when someone's got defib pads on and CPR. And it's usually just done during the rhythm check, so there's not very long to assess it. So there's some courses you can go on to get trained in this, such as the field course. And obviously most cardiology registrars will know as well. We'll be able to perform this. So I just know if Ahmed had any other comments on this as our cardio reg specialist.
Yeah, no, thank you. I think it's a very good point, and I think actually when we get called as cardiology reg, it's usually because they want an echo, and it's actually really challenging to do an echo on a patient who's in a cardiac arrest, because if you imagine, look at where our windows are and look at where your CPR is done. So your CPR basically cuts out. I mean, the main views that we use actually are the left parasternal, apical, and subcostal. So if you're doing CPR, you're not going to get any parasternal views. The main one is subcostal. Again, it's very limited. You're not going to be able to see wall motion abnormality at all. No way. You won't be able to assess that. All you will be able to see really is whether there's fluid around the heart, and that's as far as it goes, because we won't really be able to assess for tamponade in a cardiac arrest patient. We just see that there's an effusion around the heart. We see a pericardial effusion, we assume that it could be the cause of the cardiac arrest. So in terms of, actually, it's good, I'm glad you mentioned this, because sometimes it can be useful to know that when you're doing the CPR, it's actually, we won't be able to do, we won't be able to scan during CPR. So it's actually, you're right, usually when they're doing the rhythm check. So once you're doing the rhythm check, then at that stage, let the echocardiographer just put the probe on and give them 10-15 seconds to try and scan.
Yeah.
Do you mind just going back a slide?
Yeah.
And go forward. Yeah, so stop there. So in a cardiac patient, in a cardiac ward, actually, to get tamponade is relatively rare. You may see them in someone who's undergone a procedure. So they've had an ablation, or they've had a TAVI, or they've had PCI. It's rare again for PCI, but these are the cases where you see tamponade on a cardiac ward. Secondly, hypoxia is someone, they can go into acute pulmonary edema. So post-MI, they may go into acute pulmonary edema and become very hypoxic. So that's another common scenario. But yeah, and then lastly, the heart failure patients who are on diuretics, you know, on furosemide infusion, and they've missed a few days. If you've missed a few days of using these, that's a disaster. You should daily using these, because they are very, very likely to get hypokalemia or hyperkalemia, which can then precipitate cardiac arrest. So those are the commonest, they're more common actually, those scenarios. And you said thrombosis, yeah, absolutely. So if someone's had a stent, they could get stent thrombosis. That's one of the risks following PCI.
Okay. So then I'm just going to summarise the end bit of the chain of survival. So mainly this focuses on early advanced care. So this mainly happens with ICU. So they will, after you get ROSC with a patient, and they will, chat to usually the ICU consultant about whether they're going to accept the patient to ICU. But you might be asked to book scans, discuss with the family. That would be the main medical role in this kind of part of the chain of survival. Ask for an ECG, that kind of thing. So that's probably the other thing. So I don't know if anyone has any comments on this or anything they want to talk about from experience. From the ones that we have had ROSC, they either go to ICU or there's a decision made to palliate the patient based on the outcome. But yeah, I don't know if anyone.
I think this is a difficult one. I think, we're often guided by the anaesthetists and the ITU colleagues about deciding what to do with a patient, whether they are suitable for escalation. And unfortunately, there are a group of patients who you get ROSC, but actually they're not suitable for ITU, and you end up managing them on the ward. The other thing I was going to mention is that post ROSC, echo is useful to have an echo, but actually ECG is actually kind of more useful and it's quite easy to get. So yeah, get an ECG, have a look at it, look for signs of ischemia, look for any obvious arrhythmias. You often find the post-ROSC ECG can look very odd and very ischemic, but and we often get called in that situation maybe to take the patients to the lab, but we tend to repeat the ECG after sort of 5-10 minutes, and if it still remains ischemic, then we may need to take them to the lab if they've got an acute coronary syndrome or STEMI. But often you'll find very abnormal ECGs post-ROSC, which often settles down.
Yeah. Okay, so now I've just got some other considerations during the whole cycle. So just got a bit on types of arrest, just because obviously I put a picture of Christian Eriksen on the front of the first slide. So obviously, the thing that we're going to see on most arrests with a good survival are in-hospital arrests, but there is also out-of-hospital arrests. And the other thing I've just mentioned is exercise-induced, which is obviously what happened to him. So we'll go into that in more detail on the next slide. But also to bear in mind that, in the community, there is AEDs around and how they are very different from a defibrillator. So this is all an automated system. Someone who, the idea is most people would be able to use it. If you put the pads on, it'll be able to decide whether the system will be able to decide whether it's shockable or non-shockable and deliver a shock. Defibrillator has a bit more to it in terms of the things you're able to do on a defibrillator, such as pacing and manually giving shocks as you feel appropriate. So AEDs will be what is used in the out of hospital setting, and obviously this is something that the defibrillator in Christian Eriksen's situation saved his life on the pitch. So obviously important to use, and I know as a cardiology and medical community, they're calling for more people to be trained and more AEDs to be put in place following that in the community. And then I've just got a bit on.
The thing with AEDs, just in case anyone ever has, encounters them in real life, they're very easy to use. You just switch it on and you just follow the instructions. You don't have to think, you just have to follow what it tells you exactly what to do. So just all you have to do, it's not like the defibrillators where you need to kind of know how to use them. The AEDs, you just switch them on and just follow the instructions step by step. And they're actually really accurate. So if it does say shockable rhythm, you know, I think 95% plus of the time, it actually truly was, you know, shockable rhythm.
Yeah. And then I just got a bit on cardiac arrest in the athletic population. So just the importance of screening. So often patients, especially at a professional level, will be screened for, you know, they'll have an ECG, they'll have an echo, and that will be assessed by their medical team. And the importance of this really in a professional, you know, sports situation. So this is something that would be done by their sports and exercise medicine team, who might also ask for a cardiology opinion if there's anything that they feel that they need reviewing. Then differential. So in, you know, for exercise-induced athletic population, again, not an exhausted list. So I've kind of split them up into arrhythmias, so long QT, Regarda, CPVT, or I spelt that wrong, sorry about that. That's my night's brain, just doing that. Sodium channelopathies and Wolff-Parkinson's White. So again, this is why the ECG is really important. And any kind of patient who's young, who might come into A&E, the importance of making sure you look at, you know, who comes in with a different medical problem, and the importance of looking at ECG, because sometimes you can, you know, incidentally identify some of these problems. Then I've put back cardiomyopathies, so HOCM, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. Again, I've spelt something wrong there, but anyway, not an exhausted list, but just other things to think about, which is why an echo would be important in anyone who has any arrest or syncope during exercise. The other thing I've put on is progressive cardiac conduction defects. So this was taken, all this information was taken from Cardiac Problems in Young People website. I don't know much about progressive cardiac conduction defect, so I don't know if Ahmed has anything to say about that.
Yeah, I mean, that's the first time I've heard that term before. No, I'm not sure what they're talking
what they
about.
mean by that. It's just on that website, so I just thought I meant.
But certainly, you know, you've got the first group are the ones who've got structurally normal heart. So if you do an MRI scan, echo MRI scan, MRI is more detailed than an echo. It'll be completely normal. But they've got this underlying condition, which are genetic conditions, and which has implications for screening the family as well, not just the person who's got the condition. And then the second group is the structural heart disease, and yeah, by far most common is hypertrophic cardiomyopathy. You see that a lot in athletes, and sometimes it can be difficult to distinguish that from training-related cardiomyopathy or athletic heart. And then ARVC, again, that's also relatively common as well in that group. The other thing you haven't mentioned there, but the other actual thing which is also very common over the age of 40 or 35 is actually myocardial infarction.
Yeah.
So I don't know if you're going to mention that, but myocardial infarction.
I don't know if I put it on the list, but yeah. So yeah, obviously the other thing is MI, and I also didn't know how common this was, but you can also get carotid artery dissection, which obviously would cause an MI, which might be more common in the younger population.
Yeah. So you can get these, you know, these arrhythmias and things that can happen during exercise, and that's if anyone has an exercise-induced syncope, that's very, very suggestive of you know, underlying cardiac condition, whether an arrhythmia or one of these conditions. But also they can also get it in recovery as well. So that's the other thing to watch out for. If someone's been exercising and then they've stopped, you can often get arrhythmias and which can cause cardiac arrest in patients following that. The other thing is actually sometimes you find that you don't know what the diagnosis is until some time afterwards. So sometimes it takes even years sometimes before we actually get the actual diagnosis for the patient. But yeah, certainly these are the commonest things. And myocardial infarction, you have to remember that it's more common. Interestingly, there's some work done showing that people who are athletes, they ignore symptoms. So they had a look at the study looked at a lot of patients who had myocardial infarctions following marathons and things like that. And what they found is that a large proportion of them actually had chest pain, but they didn't tell anyone about it. They just thought, I'm athletic, I'm healthy, and they ignore their symptoms. So one thing to say to anyone who's athletic, or anyone who's athletic, is to tell them, don't ever ignore any symptoms.
I suppose this is also, I think you often associate MI with, an elderly person who's not very healthy, and just to kind of like say, anyone can have it. There's other things in play, such as, family history, cholesterol, other things that might not be within their control. So I think I've just put on here about family history as well, and how important that is. Any of these patients. So interestingly, this week on Nights, I have had a patient who had an out of hospital cardiac arrest. So I've just got a bit of like a case about that, and just because it just kind of like nicely summarizes quite a lot of the stuff that we've discussed. So it was a 43-year-old male who was playing squash and then stopped for a break and had basically collapsed, had bystander CPR and an AED shock, which got ROSC and then came into A&E. So this is kind of exactly what, we're saying, the how good an AED is in the community, because it essentially saved his life, but also how this is raising obviously a lot of red flags, because he just finished playing squash and he stopped for a break 2-3 minutes mid-sentence to his friend, loss of consciousness and arrest. Post-arrest echo showed a mild pericardial effusion, but that's quite common after an arrest, because obviously you're doing chest compressions. His trot was raised again. It could be post-arrest. He had no family history, and ECG showed ST depression and lateral leads, which was consistent on all of his ECGs. So obviously, this is a recent thing, so we don't actually know what happened at this point, but we know we definitely had a shockable rhythm. We just need to find out the cause. So lots of the other investigations would be important here. He might need an angiogram. He might need, a formal echo, because this was a A&E quick echo, just to make sure he didn't have a massive pericardial effusion, and he might need other tests, and he might need an ICD in the future. But yes, just to highlight, lots of this is obviously applicable to any patient that you might see, and how good AEDs are in the community.
And the key thing that he's going to need is an MRI scan.
Yeah.
That's the key thing, because MRI scans will tell, they can provide a diagnosis in a lot of patients. So if they've got hypertrophic cardiomyopathy or dilated cardiomyopathy or myocarditis or myocardial infarction, all of these differentials, all of these things can be seen on an MRI scan. So that's definitely the test of choice in this case.
Yeah. Okay, and I just put a slide about communication and situational awareness, just because I think this is something that's really important in any arrest situation, and often doesn't get enough coverage, really. So, to remember, when you're on an arrest team, you're part of a team. The kind of arrests that seem more chaotic tend to be the ones where communication isn't very good. Lots of people are doing their own thing, and to make sure you're always communicating back, usually to the leader, who will usually be hands off at the top of the bed and will have the most situational awareness. So to feed back to them when, if they ask you to do something, I've done it, or if they've asked you to assess for something, what your findings were. So just something to bear in mind in the arrest situation. you know, we need to know clearly who's leading, but also feedback any findings to the leader. And then I've just put a bit about situational awareness as well. So obviously in an arrest situation, you can become quite focused on whatever task you've been given, but to always, you know, that's why the importance of feeding back to the leader is that other things are obviously in play, and it's kind of important to be kind of aware of other things going on in the arrest situation. So I don't know anyone else who's been in an arrest, you know, that wants to have any other comments on this, but just from my experience, the ones that seem more chaotic and not as well managed are the ones you feel haven't been run well, whereas the ones where you have better communication tend to be the ones that feel like you've done everything you can.
Stephanie, that's a good question. When you're on call and you come across a patient you've never met before, when would you look for a respect form? Would you wait for someone else to come with the notes, or what would you do?
As in
like a DNA CPR form?
Oh, okay. So I think if you think someone's unwell and you're assessing them at the bedside, you can either ask the nursing staff to go and get the notes, or, you know, go and check yourself. Most of the time they'll tell you. They often know who the patients are that have a respect form. But yes, it obviously is important to check. But if in doubt, you know, legally you can start until that's been found.
I tend to find that I just actually, when I start, I just ask the question out loud to everyone who's there. Does anybody know this patient? And then you'll find either there might be a junior colleague who knows the patient, or the nursing staff, or senior sister, or, you know. And then I'll just ask them, so what's going on with this patient? You know, tell me about them. You know. So as the arrest is going, you know, so you've started the arrest, you've started the protocol, the algorithm, and, you know, then you can sort of gauge more information. And sometimes I do actually ask, is this patient definitely for resus? Because sometimes you look at the patient, you think, hang on, you know, this is very advanced age, someone in the age of 90s, very frail. You know, are you sure this is? And then, but you have to check, because there have been occasions where nobody actually knows the patient. It's been in the middle of the night. The person who's called the arrest is a HCA who doesn't really know the patient, is looking, you know, has been covering for someone else who's on break. Or, you know, these things happen quite a lot. And then the other thing is, sometimes you find that you know, I actually ask, you know, when was the last time that anybody has seen this patient? Because sometimes it's been 6 or 7 hours before, you know, they haven't seen the patient. So you don't have to know when they arrested.
Yeah. The other thing to mention here is patients often arrest or collapse in places that are very annoying, i.e. the toilet, or in a very tight cubicle, and just to be aware that can happen, and obviously that creates its own challenges. From my experience, you know, when able to, the best thing to do is to try and get the patient on a bed. Obviously that's difficult if they have arrested, but, you know, in terms of assessment, getting them on the bed is obviously much better, but just something to bear in mind as well, that you might have to coordinate with arresting in the toilet.
I think as FY1s, I think realistically what you'd be expected to do is to turn up, be able to do good quality CPR, and be able to try and get bloods, or, you know, get cannula, or an ABG. I think that's, you know, and running the analysis for the ABG, getting the notes, documenting, you know, these are the kind of things that would be expected of you. And it's really good to communicate well, and just, you know, if you've been asked to do something, to go back and say, okay, I'm doing this, you know, I'm just going to, or I've done the bloods, or I've got the cannula in, you know, getting used to that, communicating in that way. For me, when I was FY1, I found that quite difficult, quite scary, to you know, to speak out. But actually, it's really good when juniors speak out, you know, and so don't be don't be worried, don't be afraid of it. It is a difficult situation. Cardiac arrests are very difficult to deal with. Sometimes you do need to debrief afterwards, and I would encourage that and discuss it with the team. Also, outside of that situation, discuss it with your colleagues and seniors and people that you trust. Because you'll find that actually whatever you're going through, everyone else has gone through it, before.
So then I just got a bit on COVID-19. So they have found that there's been less hospital cardiac arrests over the last 12 months than the previous year. And I think a lot of this is due to, earlier discussions about escalation and better discussions, really. So that they think that's the main reason, but also there's been other changes to the resus guidelines. So this is like an infographic that the Resus Council have provided. So the main things are not to do mouth to mouth, not that we would in a hospital setting, but in an out of hospital setting. You're not to listen to feel for breathing by placing your ear and cheek close to the patient's mouth. If the patient has COVID-19, just lowers your risk of infection. To check for a pulse from arm's length away rather than being up close to the patient. You can give a shockable rhythm early because that might restore circulation and reduce the need for further resuscitation, because obviously resuscitation is an aerosol generated procedure. You need full aerosol generated procedure PPE to be applied, which often will be on the arrest trolley. And then other things kind of not really from our point of view, but there will be for whoever's doing the bag and mask, and there's viral filters that you can apply to that, which again reduces the risk of infection. Thinking about reversible causes, as I said, early discussions around resuscitation and the need for resuscitation, and make sure afterwards that everyone's, the room's cleaned, you've taken off your PPE correctly, to avoid self-contaminating. And I think they're probably the main things to mention. Again, in an arrest situation, wearing aerosol generated procedure PPE can be quite difficult to maneuver, because obviously you can become very warm very quickly. So just to bear in mind, for whoever's doing the CPR, they might need to change out more regularly to avoid overheating. Don't want somebody collapsing on you during the arrest. I think that's it from what I think. Anyone else got any comments on this?
So for the defibrillator, one of the new things is that they say you can do stacked shocks. So stacked shocks is when you see this on ER or something like that, or, dramatic shock, where they just keep shocking, shock, they're still in VF, shock again, yeah. Whereas originally before COVID, you just do one shock and then you do your CPR straight away. So that's one of the differences, that you can do stack shocks. We do stack shocks quite a lot in the cath lab environment, and actually the cath lab is probably has the highest number of cardiac arrests, I would say, in a hospital setting. So I think that's the only other thing I was going to say really about that.
Mm-hmm. So my general learning points overall is it's never too early to put an arrest call out. If you feel that someone's unwell, don't be afraid to be wrong. Always ask for help. So often, if in this situation, ask for the arrest trolley, ask for someone to put the arrest call out, because you'll probably need to stay with the patient. Try as best as you can to just remain calm and follow the algorithms. And there'll always be lots of help. As an F1, you've got multiple senior staff who'll be able to help you. So if you feel out of your depth in any way, always best to call for help. And the algorithms are there for a reason, and they're very helpful, very simple. And obviously this will be covered in your ALS, but you obviously follow the algorithms. And then the importance of debriefing and communication, because obviously these are stressful situations that happen to us, and lots can be going on at the time. And sometimes it can be, kind of days, weeks after where you start to think, oh, you know, actually I didn't really like that arrest. That was horrible. So always, you know, can speak to anybody about this, any senior colleagues or even your peers. You know, one of the best things about starting F1 is, you know, you immediately got loads of peers all at the same level, all in the same boat, and talking with them can often be very helpful for you to process what's happened. That's it, I think. And then I've just got some references there. So I don't know if anyone has anything else they want to add from this, or any questions about anything to do with this or starting F1 generally.
I think I can add something, Steph, if that's all right. So
Yeah, go ahead.
Yeah, I've come to the end of my F1 now. And yeah, it was a great talk, really, really useful. I think just from my own experience from arrests in hospital, for anyone who's, you know, starting F1 particularly, and particularly if you've not seen an arrest before, obviously it's very, very stressful, or it can be very, very stressful if it's not being led very well. But as an F1, I think as Steph, you know, very rightly pointed out, or at least I always felt in the situation, I was never in a, you know, a scenario where I was expected to do more than I should have been. It's very helpful at the MRI because your roles are dictated at the start of the shift. So I can always say, look, I'm not happy with doing defibrillation or access. I would rather do this, and everyone's always happy with that. But a big point that I do notice when, say, you get to an arrest when on the crash team, sometimes, you know, everybody wants to help, but, you know, if you've got the ward staff there, you've got a reg, you've got a couple of IMTs, you've got an F1. Sometimes you have too many people there. In as much as, you know, people can get in the way, there's lots of conversations going on, it's very loud. So, you know, never feel uncomfortable just taking a step back and just saying, you know, what's missing here, mention it to the reg if they're stressed, and just being an extra pair of eyes and saying, do you feel like, you know, is there anything else I can do? If, for example, if you're a runner, for example, for a gas, you've ran the gas, the notes are there, you're stood outside not really doing anything. I think if you just bear that in mind, it's always sort of helpful for the reg as well, because it, you know, it can be quite stressful, and sometimes you do have to try and tell people to go away and get out of the way. And I've seen that happen quite often. So, and yeah, in one of our debriefs, actually, I did raise this point, and I think the reg effectively said, yeah, that's something that I've noticed a lot of the time. So, yeah, always try and get involved, but, you know, never feel like you need to be doing something, because a lot of the time you won't be.
No, I think that's a really, really good point, actually. And that you're right, it does happen regularly. And especially, you know, if you're, you know, doing on call, or there's other things that you could be doing on your ward, it's always good to say, you know, actually, I'm not doing anything here, and I'm just, you know, just being an extra body, which actually is not always that helpful. So that's a really good point. Thank you for that.
And Steph, the squash player you mentioned, what was the outcome there? Did they find out the cause?
I'm not sure yet. So it's only happened this week. So I don't know. We don't know yet what's happened. So yeah. So just lucky that happened this week, so that I could mention it today. And it does, obviously, like I said, it does nicely tie in with lots of things.
Thanks so much for that. I'll just stop the recording just now.